See one of the important chapters that is on polyps and cancer. So this is one of the another important chapter which can be useful for you in pathology as well as in medicine. So please follow this chapter. Let me start my discussion on polyps. So polyps are coming under many headings. One of the important type of polyps is hamartomatous polyps. Hamartomatous polyps. Hamartomatous polyps are the polyps which have very less risk of malignant potential. Less risk of malignant potential. The risk will be in less than 1% like that. Very less. Less than 1% risk of malignant potential is still there. Okay, that is hamartomatous polyps. And there are hyperplastic polyps. Hyperplastic polyps have around 2% risk of malignant potential, around 2% risk. And the third polyp is adenomatous polyps. They have high risk of malignant potential. They have the highest risk of malignant potential. We have three types of adenomas. What are they? So the adenomas are tubular adenomas like this, villous adenomas like this, or tubulo with villus like this. So tubular adenoma have 5% risk of malignancy. Villus has highest risk 40%. Tubulovillus has 10 to 20% risk of malignancy. So as you see from this slide, hamartomatous polyps, hyperplastic polyps, adenomatous polyps all have a risk of malignancy. Can you tell me which polyp have no risk of malignant potential? They are nothing but pseudopolyps. Pseudopolyps and inflammatory polyps have no risk of malignancy. So there are some other polyps like pseudopolyps and inflammatory polyps. They don't have risk of malignancy, so no need to worry about those polyps. So pseudopolyps where you get in ulcerative colitis. So pseudopolyps and inflammatory polyps have no risk of malignant potential. So please don't forget hamartomatous polyps, hyperplastic polyps and adenomatous polyps. We are going to discuss one by one. Can you tell me the syndromes associated with hamartomatous polyps? Peutz-Jeghers syndrome, familial juvenile polyposis syndrome running in family, Banyan-Ruvalcaba syndrome. I'm going to discuss one by one. Banyan-Ruvalcaba syndrome, Cronkite-Canada syndrome, Cowden disease. All these are syndromes having hamartomatous polyps. Let me discuss about one by one. First, let us discuss what is this Peutz-Jeghers syndrome. Peutz-Jeghers syndrome is a syndrome associated with STK11 mutation, that is mutation seen in chromosome number 19. Okay, 19p mutation is STK11 mutation seen Peutz-Jeghers syndrome, chromosome number 19p mutation. So please don't forget the mutation numbers. STK11 mutation, chromosome number 19p is Peutz-Jeghers syndrome. They have polyps more commonly where? Hamartomatous more commonly in jejunum. They have more commonly hamartomatous polyps in jejunum, but they can get polyps anywhere, more common in jejunum. And one of the cutaneous manifestation for them is what? They have pigmentation in the lips. Repeat MCQ. A patient having pigmentation in the lips is seen in Peutz-Jeghers syndrome. And very important is they get cancer in the following places. They get cancer in the breast, ovary, thyroid. In all these places you get cancer in Peutz-Jeghers syndrome. An interesting point, very commonly asked MCQ also, there is 100 times the risk of one cancer known as pancreatic cancer in Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome there is 100 times risk of pancreatic cancer seen, and also there is risk of bile duct and gallbladder cancer. So there is also risk of bile duct and gallbladder cancer seen. So though Peutz-Jeghers syndrome is not only a problem with the polyps, they also cause cancer in breast, ovary, thyroid. 100 times risk of pancreatic cancer, bile duct and gallbladder cancer is also seen in these patients, and they have rare incidence of colon cancers also. Colon cancer also is seen in rare incidence. These Peutz-Jeghers syndrome patient, what is the most common presentation to hospital? They come to you most commonly with a bleeding from the polyps. The polyps will go for bleeding, or they can come to you with a pain abdomen due to intussusception caused by the polyps. The presentation of these patients is they can come to you with a bleeding or with a pain abdomen. So bleeding is from the polyp. So this is one of the cases which presents as occult bleeding from the stools. Occult bleeding, one of the cause of occult bleed. So one of the cause of occult bleeding is Peutz-Jeghers syndrome, and it can also cause pain abdomen due to intussusception caused by the jejunal polyps. So these are the two common presentations. So they can come to you with a bleeding or with pain abdomen. So this is about Peutz-Jeghers syndrome. Okay, and the next syndrome is on juvenile polyposis syndrome. Number 2, juvenile polyposis syndrome. Juvenile polyposis syndrome known as JPS. It is also a familial type of syndrome. They have mutation in SMAD4. It is known as SMAD4 mutation in chromosome 10q. SMAD4 mutation in chromosome 10q is known as juvenile polyposis syndrome. So Peutz-Jeghers is STK11 19p and juvenile polyposis is SMAD4 chromosome number 10q mutation. So they mainly get polyps in the hamartomatous polyps in colon. If it is a single polyp, we can do polypectomy. Just remove the polyp alone. Polypectomy can be done. If it is multiple polyp, no other way, we have to do colectomy. Please remember this point. If it is a single polyp in JPS, just to do polypectomy, that will be enough. If it is multiple polyp, we have to go for total proctocolectomy type of operations. We have to remove the entire colon in these patients. So they are associated with what are the other features? They are associated with problems in the head. Remember, they have problems in the head like hydrocephalus. They may have malrotation of gut. They may have associated Meckel's diverticulum. So you can see associated bowel pathologies like malrotation, Meckel's diverticulum are also seen in juvenile polyposis syndrome. So they have hydrocephalus, malrotation, Meckel's diverticulum all seen in these patients. They have increased risk of colon cancers. Increased risk of colon cancer is seen in these patients. Please don't forget they have risk of colon cancers. Even there is risk of pancreatic cancer like Peutz-Jeghers syndrome. There is also a risk of pancreatic cancer seen in JPS syndrome. Juvenile polyposis syndrome is also a hamartomatous polyposis syndrome. It is given by a definition presence of more than 10 polyps. The definition of JPS is presence of more than or equal to 10 polyps in the colon. So please don't get confused. Peutz-Jeghers syndrome, the polyps are seen in jejunum. In juvenile polyposis syndrome, the polyps are seen in colon. And next comes Cowden disease. You would have read about Cowden disease, one of the important predisposing syndrome for cancer, breast and thyroid. It can cause, very importantly, cancer breast and thyroid. One of the important predisposing factor of cancer breast and cancer thyroid is Cowden disease. So cancer breast is seen in 50% of these patients. Cowden disease patients, 50% of them will develop cancer breast and 10% of them will develop cancer thyroid, and they have mutation associated with chromosome 10q mutation. So most of them have chromosome 10q. Cowden disease, juvenile polyposis syndrome also 10q mutation seen. So they have polyps in the stomach and colon. Cowden disease will have polyps in stomach and colon. Please don't forget they have polyps in stomach and colon, and they cause problem in colon cancer is seen in these cases. So colon cancer is seen in Cowden disease. And another syndrome is from subsystem Banayan-Ruvalcaba syndrome. Banayan-Ruvalcaba syndrome. So the name looks funny. Very rarely they ask MCQs in this syndrome. They are associated with chromosome 10q mutation. They are also associated with chromosome 10q mutation. Please remember all these syndromes I am discussing are all autosomal dominant only. So Banayan-Ruvalcaba syndrome also develops hamartomatous polyps in the colon. Hamartomatous polyps in the colon, and associated with this is an expected MCQ for super specialty. They have glans penis pigmentation. Like pure sugars have pigmentation in the oral lip, this fellow has pigmentation in the glans penis and dysmorphic features. His face will be dysmorphic and he will have macrocephaly. Dysmorphic features are present and macrocephaly is present in Banayan-Ruvalcaba syndrome. So you can understand from the 3 hamartomatous polyposis syndrome I explained, all the syndromes are chromosome 10q mutation except Peutz-Jeghers is 19p mutation. Even if you forget other syndromes, don't forget Peutz-Jeghers. Peutz-Jeghers is a mutation in STK11, chromosome 19p mutation. The polyps are most commonly seen in jejunum. They have oral lip pigmentation. 100 times risk of pancreatic cancer is seen in these cases. So please don't forget 100 times risk of pancreatic cancer in Peutz-Jeghers syndrome. They come to you with the bleeding and pain abdomen. Okay, please don't forget Peutz-Jeghers. Juvenile polyposis is defined by presence of more than 10 polyps in the colon with SMAD4 chromosome 10q mutation. Cowden disease, when you tell Cowden disease, you should think of CA breast and CA thyroid. But they may also have polyps in colon and stomach and cause cancer in colon. Banayan-Ruvalcaba is again compared to Peutz-Jeghers. It will have dysmorphic facial features and it will have macrocephaly and glans penis pigmentation. So all these hamartomatous polyposis will have some risk of malignant potential in the colon. And coming to the tubular adenomas and villous adenomas. This is tubular, this is villous. Tubular adenomas have pedunculated polyp appearance. They are all mostly pedunculated. Villous adenomas are mostly sessile polyps. They are mostly sessile polyps. So please don't forget tubular adenoma has pedunculated appearance like this. To be drawn ideally like this. They have a pedunculated appearance. This is head, this is neck, this is stalk, this is base of the peduncle. In sessile, there is no such head, neck, stalk, and all. It is sessile. So now, with this in mind, you can remember this is polyp, this is sessile polyp. With this in mind, you have to remember one criteria known as Hagid's criteria. What is this Hagid's criteria telling? Hagid's criteria tells which polyp can go for, how the polyps go for cancer. Hagid's criteria is defining the depth of invasion of cancer in the polyps. So usually it is the polyps from which cancer starts. The cancer is starting only in the head. It is involving the head alone and just infiltrating up to the mucosa and submucosa involving only head is known as level 1. That is known as level 1. If the cancer is infiltrating up to the neck, it is level 2. It is infiltrating to the stalk, it is level 3. If it is infiltrating to the base, it is level 4. This is for tubular adenomas. In tubular adenomas, how many levels are there? In tubular adenomas, the cancer is infiltrating into the submucosa. The submucosa up to head of pancreas is level 1, neck is level 2, stalk is level 3, coming up to base is level 4. In sessile polyp, there is only one level. What is that level? Directly, it is level 4 only. Or in villous polyp, there is only one level known as level 4. So this is Hagid's criteria of infiltration of polyps. Hagid's criteria of infiltration of polyps with the cancer is known as Hagid's criteria. So I used to remember as HNS, head, neck, stalk. HNS is level 1, 2, 3, and then coming to the base is level 4 for tubular adenomas. For sessile adenomas, there is only one level, that is level 4. Please don't forget this is expected need question, Hagid's criteria. It is an expected need question known as Hagid's criteria, high yield MCQ for your exams. Okay, please don't forget about this Hagid's criteria for your exams. Now, next I am going to discuss about tubular adenomas, important syndromes and mutations. Tubular adenoma syndromes we are going to discuss. So can you tell me what are the two important syndromes or mutations associated with tubular adenomas? They are FAP, familial adenomatous polyposis, and another one is HNPCC, hereditary non-polyposis colorectal cancer syndrome. So FAP and HNPCC are the two important things you should not forget. FAP is associated with 5q mutation. It is autosomal dominant. Familial adenomatous polyposis is associated with 5q mutation. It is autosomal dominant syndrome. HNPCC is associated with microsatellite instability. What is this microsatellite instability? This is an important thing you should not forget. Microsatellite instability is a mutation of what gene? Mutation of MMR, mismatch repair gene. In a formation of DNA, adenine will bind with what? Adenine will bind with thymine, cytosine will bind with guanine. So adenine will bind with thymine and cytosine will bind with guanosine. So this is a normal binding. If something happens abnormal, for example, A binds with G, this pair is removed by this mismatch repair gene. So the repairing fellow is mismatch repair gene. If that fellow himself is repaired, the fellow who repair himself is getting repaired is known as mismatch repair gene. Please don't forget. The fellow who repairs himself is getting repaired is known as mismatch repair gene mutation that results in a microsatellite instability characterized by so many cancers. It is associated with MLH1 mutation, MSH2, MSH6. These are some of the mismatch repair genes. MLH1 is most common mutation. MSH2, MSH6 are the other, and the chromosome numbers are usually chromosome 237. The chromosome mutations are located on chromosome 237, and this is mismatch repair gene mutation. So please understand the differences. I'm going to tell the differences between FAP and HNPCC. So this is bubble wall. In FAP, there are more than 100 polyps seen. Please don't forget, there are more than 100 polyps in the colon. Familial adenomatous polyposis syndrome, to define it, you should have hundreds of polyps in the colon. If you have less than 100 polyps of colon, it is known as hereditary non-polyposis colorectal cancer syndrome. What is HNPCC means? Hereditary non-polyposis colorectal cancer syndrome. So it is a misnomer. It is not non-polyposis. They also have less than 100 polyps. So HNPCC means they also have polyps, but less than 100. FAP has more than 100. Okay, that point you should not forget. Which is common of this? FAP is common, HNPCC is common. HNPCC is 3 to 5% incidence of colon cancers. FAP is only 1%. So HNPCC is more common. HNPCC is more common to get in this community. So what happens to FAP boy? If a boy born with FAP, let us assume this is a boy born with FAP. There's a newborn boy, newborn baby with FAP. What are the things this baby is going to experience in life? This baby will develop polyps from 10 years. From 10 years, they develop polyps. From 10 years onwards, they start developing polyps. Before high school means before 20 years, they also start developing cancer. Before high school, they develop cancer, also start developing cancer. By 10 years onwards, they start developing polyps. Before high school, they are not mentioned as 20 years, so we keep it as before 20 years. And by age of 40 years, they all will die of colon cancers. This is the life of FAP. So life of FAP is 10 years, they develop polyp, 20 years, they develop cancer, by 40 years, they will die. So what to do for these guys therefore? So therefore, we have to do, from 10 years onwards, we have to do colonoscopy surveillance. Colonoscopy surveillance must be started. So how to diagnose or how to screen for APC? The most common mode of screening for them is by means of testing for APC truncation mutation. If you suspect there is FAP, you should do APC truncation mutation. This is a MCQ asked from pathology. You have to look for APC truncation mutation as a screening method to diagnose FAP, familial adenomatous polyposis. If you want to screen, you have to do APC adenomatous polyposis coli gene truncation mutation. If you want to confirm, you have to detect APC mutation by confirmation is by DNA sequencing. Confirm by DNA sequencing. Please don't forget this. When you do DNA sequencing, a classic FAP patient, classic familial adenomatous patients will have mutation from which mutation? From 1250 codon to 1460 codon. There will be mutation seen. This is a classical FAP. So if this is a 5' to 3' end gene, in this gene there will be mutation specifically from 1250 to 1460 codon mutation will be seen. This is classical FAP. Mutation proximal to this mutation seen, proximal to 1250 or distal to 1460 are known as attenuated FAP. They are known as attenuated FAP. So DNA sequencing is best to confirm the FAP, but to screen we can use APC truncation mutation. APC truncation is used for screening. So confirmation is by DNA sequence. We have 1250 to 1460 codon mutation is seen, and attenuated FAP is a mutation seen proximal to 1250 or distal to 1460. That is known as attenuated FAP. And usually that attenuated FAP patients will have no rectal polyps. Please remember, especially if the mutation is proximal to 1250, there will be no rectal polyps seen in those cases. There will be no rectal polyps will be seen in those cases. This is a super specialty question. So rectal polyps will be absent in mutation proximal to 1250 or 5' end. Towards the 5' end, rectal polyps are less common. So this boy who is born with the polyps at 10 years, what I will do? From 10 years onwards, I will start colonoscopy surveillance. Remember that point. From 10 years onwards, I will start colonoscopy surveillance. And what should I do before 20 years? Since he can develop cancer before 20 years or before he enters high school, I will do an operation known as prophylactic total proctocolectomy with ileal pouch anal anastomosis. Same way did for ulcerative colitis. Same operation. Prophylactic total proctocolectomy with ileal pouch anal anastomosis is done for patients less than 20 years. At that age itself, we should do this. Otherwise, they will develop cancer from 20 years onwards and they will all die before 40 years. So prophylactic total proctocolectomy with ileal pouch anal anastomosis should be done before the boy goes to high school. So now this procedure is done. Now the patient is comfortable, is living happily, and in spite of this surgery being done, there is a second most common cancer seen. What is it? Second most common cancer seen in FAP is what? Second most common cancer is periampullary or periampullary duodenal cancers. Near the duodenum in the periampullary region, they can develop second common cancer. So they can develop cancer in the periampullary and duodenal region. Therefore, we should start surveillance for this after 20 to 25 years onwards. We should keep surveillance by upper GI scopy. So this is how the life of FAP goes. This is how the life of FAP patient is going to go on. Okay, we have to do endoscopy from 20 to 25 years onwards. Keep them on follow up for these patients. So remember this FAP one side. Then only you can understand HNPCC on the other side. So now I am going to discuss HNPCC, hereditary non-polyposis colorectal cancer syndrome. It is again an autosomal dominant associated with chromosome 237 mutation, mismatch repair gene mutation. Please don't forget this. This is responsible for 3 to 5% of the cancers in the colorectal area. Now HNPCC, a girl is born. HNPCC, a girl is coming to you. When will she start developing polyps? She will start developing polyps like FAP fellow at 10 years. This girl will start developing polyps at 20 years. And by around 50 years only, she will start developing cancer. Cancer in the colon. From 50 years, around 40 to 50 years, around she will start developing colon cancers. So therefore, what I will do for this girl? I will start doing colonoscopy surveillance for this girl from which age? Colonoscopy surveillance started for this girl from 20 years onwards. I will keep her on colonoscopy surveillance. 20 years onwards, I will keep her on surveillance. And I will do colectomy. When will I do total colectomy? Total colectomy I will do not before. I will do only when she develops cancer at around 40 to 50 years. As she develops cancer, at that time I will go and do. I won't do a prophylactic surgery for HNPCC, but I will keep them on follow up from 20 years and I will do it at 40 to 50 year age group. An interesting point in this girl is there is a second most common cancer seen in this girl. What is the second most common cancer seen? The second most common cancer seen in this girl is endometrial cancer. Please don't forget this point. Endometrial cancer is the second common cancer seen in this girl. This starts developing from 25 year onwards. Therefore, I should do transvaginal sonogram and DNC from 25 year onwards to these girls. So I should start doing transvaginal sonogram and DNC should be used as a surveillance of these patients. So please don't forget, FAP patient 10 years he develops colonic polyps. So therefore, from 10 years I will do colonoscopy. HNPCC girl start developing polyps from 20 years. So I start doing colonoscopy from 20 years. For your exam, please don't forget the second common cancer in each. Second common cancer in FAP is duodenal periampullary cancers. And second common cancer in HNPCC is endometrial cancer. So duodenal periampullary cancer starts from 20 years onwards. Endometrial cancer starts from 25 years onwards. Therefore, the second surveillance is with upper GI scopy for duodenal cancers and transvaginal sonogram and DNC for HNPCC cancers. Please don't forget these points. And FAP, the cancer is common on left colon, most common on left side colon. In HNPCC, cancer is most common on right side colon. HNPCC, there is synchronous cancers and metachronous cancers are very common. Metachronous cancers are present. Synchronous and metachronous cancers are seen in HNPCC, not seen in FAP. And in FAP, we have syndromes known as Gardner syndrome and what else? And Turcot syndrome. Yes, HNPCC has mutations in syndromes associated with HNPCC are Lynch 1, Lynch 2. So please don't forget, FAP associated syndromes are Gardner and Turcot, HNPCC associated syndromes are Lynch 1, Lynch 2 and Muir-Torr syndrome. Muir-Torr syndrome are the syndromes associated with HNPCC. So now let me tell you what is Gardner syndrome. Each syndrome, let me explain you. All these are important for your exams from pathology, not from surgery but from pathology. So Gardner syndrome is FAP, familial adenomatous polyposis, APC gene mutation associated with the following. What are the following? They will have associated CHIRP. Very common extra intestinal manifestation is CHIRP. What is a CHIRP? Congenital hypertrophy of retinal pigment epithelium. Congenital hypertrophy of retinal pigment epithelium is known as CHIRP. Congenital hypertrophy of retinal pigment epithelium is known as CHIRP. And we have associated desmoid tumors. Desmoid tumors. We have exostosis of the bone. We have epidermoid sebaceous cyst. Epidermoid are also known as multiple sebaceous cysts on your body. Okay, they are all skin manifestations. CHIRPs, desmoid tumors, exostosis, sebaceous cyst, and Gardner syndrome has these are all other features associated with Gardner syndrome. CHIRP, desmoid tumor of the abdominal wall and mesentery, exostosis, epidermoid, multiple sebaceous cyst. And there is another syndrome, Turcot syndrome. The important difference is Gardner is autosomal dominant, Turcot is autosomal recessive. This is FAP, APC gene mutation associated with what other problem? Associated with brain tumor. What is the name of the brain tumor? The brain tumor is medulloblastoma here. Please don't forget the medulloblastoma is associated with Turcot syndrome or FAP, the brain tumor is medulloblastoma. So FAP, once you diagnose, the management is going to be simple, straightforward. We will do in all these cases like Gardner syndrome, Turcot syndrome, all these cases, you should straightforward go for prophylactic total proctocolectomy with ileal pouch anal anastomosis before patient goes to high school. That is answer. Please remember this. So that is answer. Prophylactic total proctocolectomy with ileal pouch anal anastomosis before the patient goes to high school is answer. And if it is a patient of HNPCC, he may have the following syndromes: Lynch 1, Lynch 2, and Muir-Torr syndrome. All these are autosomal dominant syndromes. Lynch 1 is colorectal cancer syndrome only. That is only known as Lynch 1. Lynch 2 is colorectal cancer associated with other cancers like extraintestinal cancers also. Associated with extraintestinal cancers is known as Lynch 2. What are the extraintestinal cancers? The first common cancer already told you is endometrial cancer. Endometrial cancer is seen in around 50% of the cases. Remember the mnemonic ego. So E for endometrial first, second gastric cancer is associated with Lynch 2, then comes ovarian cancer. So this is the order: gastric, ovarian. Ego is the mnemonic for extraintestinal cancer. Not only ego, there are also other cancers like SP tub. Special tub, remember like SP tub. The other cancers associated are small intestine cancers, pancreas cancers, and thyroid cancers, urinary tract cancers, and brain tumors. So remember the mnemonic ego tub, ego special tub, ego, E endometrial, G for gastric, O for ovarian. So small intestine, pancreas, thyroid, urinary tract, brain. The brain cancer which is most common in this place is glioblastoma. The brain cancer common here is glioblastoma is the most common brain cancer here in this. So please don't forget ego, EGO. Endometrial is the most common cancer, G for gastric, T for ovarian. So this is the order. And Muir-Torr syndrome is a cancer, HNPCC associated with multiple sebaceous cysts. So there are two syndromes associated with multiple sebaceous cysts. They are Gardner syndrome and Muir-Torr syndrome. Muir-Torr is HNPCC associated with multiple sebaceous cysts. So these are the two important polyposis syndrome, FAP and HNPCC. So the important differences here are FAP starts developing polyp from 10 years, HNPCC from 20 years. FAP second common cancer is duodenal cancer, HNPCC the second common cancer is endometrial cancer. And which is most common? HNPCC is most common. 3 to 5% of colon cancers are associated with HNPCC. Therefore, to look for HNPCC, we have a criteria. What is the criteria known as? To know if you are having a doubt, sir, will I develop HNPCC? If I am asking you a question, sir, will I develop HNPCC? Yes or no is given by the answer. The criteria known as Amsterdam criteria. So Amsterdam criteria says whether you can develop HNPCC or not, or will you have HNPCC mutation or not. Number 1, in your family, 3 members affected of colorectal cancers. Are there 3 members in your family affected of colorectal cancers? And 2 of them are first degree relatives. Among these 2 guys are first degree relatives. Fathers and brothers like that, first degree relatives. 2 are first degree relatives, and 1 fellow developed before the age of 50 years. Among these guys, at least 1 fellow developed before the age of 50 years. And there is no FAP. FAP excluded, easily excluded. FAP is excluded. That is known as when you fill up this 4, you are chances of having HNPCC. You are having chances of getting a HNPCC. Amsterdam criteria says in your family 3 members affected of colorectal cancer. Among the 3, 2 are first degree relative, 1 fellow less than 50 years, and FAP excluded. This is known as Amsterdam criteria. This is known as Amsterdam criteria. Repeatedly asked in names. There is one more criteria known as modified Amsterdam criteria. So in this criteria everything is same, but they not only take the colorectal cancer, they also take up the other cancers like Caesar. So they also take the 5 other cancers remembered by mnemonic Caesar. They take up in one family 3 members affected of cancer, 2 are first degree relative, 1 fellow less than 50 years, and FAP excluded. And the cancers are colorectal cancer, endometrial cancer, please remember endometrial cancer, and stomach cancer, urinary tract cancer, or renal cancers. Any of these cancers are also seen. Stomach or small intestine cancer are also seen. So modified Amsterdam is not important for PG. So for PG, please remember modified Amsterdam, we have other cancers are also included. And there is one more criteria also is given in substance, that is Bethesda criteria. Bethesda criteria not only takes cancers, it also takes into criteria. Polyps are also taken. Polyps are also taken into criteria. So not needed to remember Bethesda, but remember the three criteria to diagnose HNPCC in the community are Amsterdam criteria, modified Amsterdam criteria, and Bethesda criteria are the three criteria we have to take up into the community to look for the syndrome. Okay. So HNPCC is 3 to 5% incidence, and therefore there are more chances of getting colon cancers because of HNPCC. Therefore, you should know to identify HNPCC from the community. So what is the treatment of HNPCC people? Usually they develop cancer at around the age of 40 to 50 years, and their right side colon cancers, usually they are right side colon cancers and develop at around 40 to 50 years, and usually they may have synchronous as well as metachronous cancers. Metachronous means they may at the same time come to you with a cancer in the liver. So therefore such patients, once they develop cancer, at that time you go and do total colectomy. At that time you should go and do total colectomy for these guys. So please remember, at that time you should go and do total colectomy for these guys. And if those who want an extra edge in this topic of polyps and other things, extra edge points I like to tell for those who are preparing for institute exams, extra edge point is number 1. There is a classification known as Spiegelman classification. What is this for? Spiegelman classification is for duodenal polyps. Is for duodenal polyps in FAP patient going for cancer. And based on this classification, we will decide when to do Whipple's operation. Based on this classification, we plan Whipple's operation. When to do Whipple's operation is decided based on this Spiegelman classification. Because the duodenal polyps will go for cancer. That is Spiegelman classification of FAP. For FAP duodenal polyps, remember the heading alone. FAP duodenal polyps, that is a classification known as Spiegelman classification. So what is the treatment of choice for FAP? I told you, answer is prophylactic total proctocolectomy with ileal pouch anal anastomosis. So you can see in this operation, I am removing what? I am removing the rectum. But when I am doing this operation, before high school, very young fellows, 18 years, 17 years, I will be doing this operation. So when I am doing a rectal operation, there is definitely a damage of the nerve supplying the genitalia, and there is decreased sexual activity seen in these patients. Therefore, in young age, in young males, please remember, in young males with mutation at 5' end, if there is a mutation with no rectal polyps, on examination, no rectal polyps, these guys alone we can do another operation known as total colectomy with ileorectal anastomosis. Please remember, this is a super specialty question maybe asked for you. So young males with the mutation at 5' end, no rectal polyps seen, I can go for an operation known as total colectomy with ileorectal anastomosis. Can be done for these guys. Okay, can be done for these guys with the 5' end mutation. Please remember, with the mutation at the 5' end. So this is a picture from alien love. You can see this is a picture showing you classical oral lip pigmentation in Peutz-Jeghers syndrome. In Peutz-Jeghers syndrome, oral lip pigmentation. So this is Haggett's criteria. I told you what is Haggett's criteria for the polyps going for cancer. Level 1, it is going to the head. This is neck. 2, 3 is top, going to the base is 4, and for sessile polyp there is only one level, that is level 4. Please don't forget that point. So these are the colonic polyps. You can see the typical colonic polyps. So which polyp has 100% risk of malignant potential means familial polyposis coli have 100% risk of malignant potential. Villus adenoma has 40% risk of malignant potential. So please don't forget FAP 100% risk of malignant potential. And these are the Peutz-Jeghers having jejunal polyps on a capsule scopy. On a capsule scopy, we are picking up a polyp. So this is a classical FAP, hundreds of polyps in the colon, and this is one of my patients with hundreds of polyps in the colon. We have done a total proctocolectomy with the end ileostomy was done for this patient, and afterwards we did a total proctocolectomy with ileal pouch anal anastomosis was done. So what is the earliest phenotype change present is aberrant crypt formation. This is a screening method. How to screen FAP is by looking for aberrant crypt mutation. Okay, please don't forget this patient. And when will they die? All of them 100% will die by the age of 40 years if you left them untreated. This is a HNPCC mutation. MLH1, MSH2, MSH6 mutations are known as HNPCC. MLH1, MSH2, MSH6. So please don't forget they are autosomal dominant and they are responsible for 3 to 5% of the colonic cancers, and they are predominantly right side colon cancers. Lines 1 means only colorectal, and lines 2 means remember colorectal plus extra intestinal like ego. And colorectal cancer FAP, when will you start screening? 10 years. HNPCC at 20 years. And if duodenal cancers start screening from 25 years, endometrial from 25 years. Okay, the second common cancers. So please don't forget Amsterdam criteria, modified Amsterdam criteria, Bethesda criteria are the various criteria from Sabiston. So please don't forget, start your colonoscopy screening at 10 years in FAP and at 20 years in HNPCC. These are the various other cancer screening protocols, not essential for you. Okay, so that completes the polyps. So the polyps topic is getting over by this. I hope you understood what are the various syndromes. What is in which syndrome you get gland venous pigmentation? Banai and Ruvalcaba syndrome. What mutation is it? Chromosome 10 mutation. In FAP, we get Gardner syndrome, Turcot syndrome. In Gardner syndrome, what is the most important, most common extra-intestinal manifestation means congenital hypertrophy of retinal pigment epithelium known as CHIRPY. Please don't forget, 80% to 90% of them will have CHIRPY. Congenital hypertrophy of retinal pigment epithelium. Okay, and in familial juvenile polyposis syndrome, more than 10 polyps are seen. And who will have malrotation of gut or Meckel's epithelium, etc. They are nothing but FAP patients. Sorry, familial juvenile polyposis patient will have Meckel's and malrotation of gut. Please don't forget, juvenile polyposis may have malrotation Meckel's associated. Okay, so these are the important points. Please don't forget these points from polyps. Thank you.